What are some common reasons that you find that a woman's not getting pregnant? Maybe things that aren't typically thought of, things that are missed a lot. What do you see for those?
I mean, number one on my mind is endometriosis. It's just
Yeah.
so easily missed. It takes so many forms, and everyone thinks it's just severe pain during your period. They think those are the two symptoms, but it
Mhm.
takes so many forms in so many women. So it could be infertility, extreme fatigue, iron deficiency, anemia,
Right.
GI issues, either constipation or diarrhea, or IBS as a diagnosis, interstitial cystitis, radiating pain, or no pain sometimes, and mainly infertility and a lot of brown bleeding, for example, at the end of the period.
All right there. Hello, you guys. Welcome back to the show. I am really excited about my guest. We're doing a topic we've never really done before and getting into all these nuances in terms of fertility. So, a lot of my favorite guests are the ones that I just like organically follow online. And I'm like, this person really has some cool stuff they're sharing. And that's exactly who this guest is. I've been following her on Instagram for a while. I love the content she shares. I think she provides a perspective that you don't see a lot in, modern medicine in terms of the fertility space. So she's super smart, super interesting, and I'm excited to share her with you. So a little bit about my guest, Dr. Naomi Whittaker. She's a board certified OB-GYN, certified Creighton Model Fertility Care instructor, and she also is a surgeon too, so reproductive medicine surgeon. She has a specialty in natural fertility. And she's a 2013 graduate of Creighton University School of Medicine in Omaha, Nebraska. She's actually in Pennsylvania now, though. She completed a residency in obstetrics and gynecology at University of Illinois College of Medicine, Peoria in 2017. And she is also fellowship trained in medical and surgical NAPRO technology. So we'll talk about what that is. She founded the rrmacademy.org. So we'll hear more about what that is. And she's also the physician lead at UPMC Divine Mercy in Pennsylvania, which provides obstetrics, comprehensive gynecology, natural fertility, as well as obstetric care. So she does it all. She's doing shifts in the hospital. She's doing some telehealth here. She's in the OR a couple days. She's doing clinic days. The girl gets around, and it's amazing. And I love everything you're doing. So welcome to the show. It's so good to have you.
Thank you. It's such an honor. Thank you for such a wonderful and kind introduction.
I was all over the place, but yeah, no, it's
Yeah,
you're
that's fitting for
clearly
me.
you're
I'm all over.
multi-passionate. You can tell you have a lot of passion. You clearly, it seems to me like you really like what you do, and I think especially what you do, women need it so much, and they're just struggling in this area with fertility, and just so much of it gets missed that needs to be identified. For one, I mean, what you guys provide is figuring out what gets in the way of someone getting pregnant. But sometimes the treatment for that is beyond just take the supplement and do this detox. There are actual procedures that oftentimes are the best fit for these people, right? And then that is oftentimes what addresses the roadblock that gets in the way of them getting pregnant. So I did want to talk about that more in terms of the procedures that you do, but just a little bit for people who are still learning about you, want to know more, like why did you even get into this world of fertility in the first place?
Yeah. So before, when I was looking into going to medicine, I was really wanting to do something that really impacts the whole person and the whole family. And I was really fascinated with hormones and endocrinology. Those are the things I kind of thought of before I went into medicine. And I also really like hands-on things. And I didn't put all this together until I did my rotations. And I had recently had a less than optimal experience under my own gynecologic and obstetric care, and saw the contrast between just kind of standard medical approach to women's health contrasted to this restorative approach in my medical school because it was developed at Creighton Medical School. And so
Mhm.
it really spoke to me because I was not satisfied with the care that I got, with I was in such a vulnerable position, and I felt like a number, and I had complications as a result. And I just I felt like things could be so much better. And when I did my OB-GYN rotation just a few months later, that experience was validated, and I saw it over and over again. And just the cookie cutter approach to women's health that wasn't individualized. And then I saw the more holistic approach to these really complicated surgeries, really intricate hormone testing and treatment. And women would fly to Omaha, Nebraska, middle of nowhere, from
Mhm.
all over the world to get this type of care. And it was so unique and it just really appealed to me because it was so interesting. It was this puzzle. It was everything I loved. And I realized I really enjoyed surgery and fixing things, seeing things get better, which in other fields of medicine are less tangible.
Yeah.
That complicated hormone puzzle on the other end, and just really those complement each other for the whole person approach. And then you add the emotional and spiritual aspect of infertility or
Yeah.
just women's health, right? That I mean, if you help women young, that impacts their future fertility. There's so many, there's such a ripple effect from fertility and women's health for her family, for society, that I tried not to do it. I tried to look away, like, okay, I didn't see this amazing thing that could be done, and that almost no one's doing this approach. I had just started my family, and that's kind of what led me to my personal experience in women's health for the first time and being kind of, oh my gosh, this is pretty abysmal compared to all the amazing advances we had in like, for example, heart attack care and these kind of things. And then women's health felt so antiquated and boring. Like, oh, here's a pill for everything. And I thought, oh, well, that's not
Right.
intellectual whatsoever. That didn't interest me because actually, when I first started medical school, I said the one field of medicine I don't want to do is women's health because
Huh.
or OB-GYN because I thought it was just pap smears and STDs
Right.
and birth control. That's all I thought. And so when I saw this, I thought, oh man, I don't want to do the hours. But when I saw the impact it could have on women when they're most vulnerable, because I had, uh, I was, when I really realized I didn't trust my OB-GYN with my personal well being, it wasn't his first priority, is what I felt at the time. I was stuck to the bed with an epidural. And so I felt so vulnerable. And my grandmother died after a C-section too. So there were a lot of layers to that. And he said, "Oh, you need a C-section out of nowhere." And
Mhm.
I, I felt that vulnerability. And once you feel something like that, you really can see, you understand the impact that this has. And I eventually said yes to that. I really felt like it was a vocation for me.
Yeah, it chose you. You didn't have a say in the
It
matter.
chose me, and
Yeah.
the lifestyle I was afraid of, which is challenging. But like I told you earlier, I have amazing midwives and nurse practitioners and colleagues that help with that to make it. I do have, work-life balance, so that helps a lot. I really looked for a practice that would help me do that.
Yeah.
And
You wanted to make an impact and you clearly are. So, goal achieved on that. So yeah, well, I love that story. I find, for us with what we do in practice, it oftentimes is so personal. And a lot of times it's, a noble motivation to do it and does choose us for sure. I feel the same with my career as well. So what I love the specialties that you have so much expertise in. Let's talk about some of these fertility surgeries that you provide. So can you tell me kind of the main ones that you typically do?
sure. So most of the time, women come to me with either their chief complaint of either infertility or pain, sometimes both. So I could have a young woman coming to me for pain. She doesn't know she has infertility, or I could have someone with many years of infertility, has seen 5 to 6 doctors or more, have been told they can't find anything, just do XYZ, algorithm, IUI,
Yeah.
IVF. Perhaps they've tried it, or perhaps they said, look, I don't want to do that. So they come to me and my fantastic fertility nurses do screening with them. We have them do cycle charting, meet with my nurse practitioners who are brilliant, and we ask them a lot of questions. And I list a lot of them on my 3-tier endometriosis symptom self-survey that's available for free online, to give us an idea of kind of how severe their symptoms are, and what suspicious symptoms for endometriosis do they have. We'll see what their cycle charts are saying, what other history they bring up, and we walk them through hormone testing and treatment based on their individual cycle data and potentially supplements and medications to optimize their health, insulin resistance, thyroid, autoimmune, as you do, and try to correct them that way medically, right? Medically
Hmm.
and lifestyle first line.
Love it.
Yeah. Right. And
Groundbreaking. Just that right away is like,
base,
wow.
but really it's that in-depth investigation, right?
Yeah.
Even just asking questions and listening, women, they're floored,
They're
right?
like,
They're just like, you listen to me.
yeah, wow. I didn't have to rush through all my questions in 7 minutes. It's amazing.
And it's sad that the bar is so low, I say. Like, that's all I could do. And
Right.
that's it. I could be done. And people would be so happy.
Uh-huh. It's so
But
true.
we try to, we really want to do more. That's why we're here. And it's sad that the bar is so low. And I love jumping over the bar, obviously.
Right. It feels
But
good.
but that's just where, right? That's where women are. I mean,
Yeah.
and when one thing about this survey, I didn't know it's not studied. It's just my brain on paper. It's just levels of suspicion of certain symptoms. It's not diagnostic. But what I found during the survey, it's more of objective data. Let's quantify a woman's suffering when she's coming to me, and it gives us just a lot of information, kind of where to go, how to educate her, and it's between that and the cycle chart. It's just so phenomenal. Just this data that we have to teach her and
Hmm.
then give her an informed choice. So, look, you have some signs of endometriosis. The only definitive way to know for sure is with surgery. We can do these other things like imaging, like ultrasound to screen for it. We can look at your cycle chart and look for red flags and kind of put those together. But really, the only way to know is surgery.
Right.
So, I see these red flags as a check engine light is on, and surgery is looking under the hood of a car, especially if other things haven't worked.
Hmm. Right. That makes sense. So yeah, tell me more about these specific procedures, like the different types that you're doing.
Sure. So, especially for infertility, I'm going to really lump a lot of
Yeah.
diagnostic tools together because I started to explain it like the Swiss cheese model, where you really have to have the holes of the Swiss cheese line up to cause infertility. It's usually not just one thing, it could be one big thing, but typically it's multiple things, maybe one medium thing and five small things, or two large things, either on the male or female side, right? And so those really stack up. So, to really get to that root cause in a surgical way, is to check everything inside the uterus, outside the uterus, the
Hmm.
proximal tubes, the distal tubes. So where the tube inserts into the uterus, where the tube is exits into the abdomen, where it captures the egg. The
Hmm.
inside of the uterus to see if there's infection, inflammation, polyps, septum, or some mechanical or inflammatory barrier to
Hmm.
sperm or implantation. Both of those can be impacted by a hostile environment in the uterus.
Hmm.
Or any abdominal barrier. So, scar tissue that could trap the egg,
Hmm.
endometriosis that's inflammatory and be toxic to eggs, sperm,
Right.
conception, transport of the embryo, as well as implantation.
Hmm.
Or just some random tube issue that happened at the end of the tube that you can only see with laparoscopy. So, looking with the camera, there's just nothing that compares to that, unfortunately. I would love to say, oh, there's this magic blood test, there's this magic ultrasound that can find everything, but it's going to miss things. All
Yeah.
the time, I don't trust ultrasounds. They're a great tool to kind of guide counseling and suspicion of complexity of the disease. But
Hmm.
majority of the time in my infertility patients, or even pain, the ultrasound is normal. And that's so frustrating because they're like, my ultrasound's normal, so I'm fine. My HSG was normal, so it's fine. But my study that I do with the tubes is much more accurate than a regular HSG. It's called a selective HSG.
Hmm.
So it can detect, it's a lot more sensitive. So it's going to pick up a lot more problems that is missed by a regular HSG. And on top of that, it's therapeutic. So it doesn't just diagnose an issue, it treats it. So I have a special instrument that can go up into the tube where it inserts into the uterus. And I have a pressure gauge and it measures very tiny pressures. So I can detect even a very small obstruction, which is really important for natural fertility.
Yeah.
And so if there's even a spill, but the pressure is high, I take a guide wire and I clean it out like snaking a sink. And I can optimize that opening because sometimes I find a little bit narrowed cervix. Both tubes are partially occluded, a little bit of inflammation in the belly. And then all of those will add, and then add just a little bit of male factor, and boom, it's been years.
Right.
Just open that gateway up. You get the sperm up in there. Boom, we're happy.
Get the sperm up in there. That's all you
Yeah.
gotta do. That's really cool. Do you find it's rare that you're doing a surgery and you don't find anything going on? Like, is there usually something that you'll find?
For infertility, I can't recall any that I didn't find anything. Usually I
Really?
tell patients that's their biggest fear. I hope you find something. And I say, I hope I don't
Yeah,
find too much. That's me, actually.
right,
I mean, almost never is too much, but I just don't really want it everywhere. I don't like it when endometriosis is on your diaphragm and your appendix and your large bowel. And,
right.
here I'm thinking worst case scenario. I don't want you to face that choice of, do I need to do a really invasive, diaphragmatic treatment or bowel resection? Those are rare, but if we get to that point, that's not a fun conversation. Um,
Yeah,
so I hope to find
definitely.
mild disease because both are extremely beneficial for fertility, removing any and all endometriosis.
What are some common reasons that you find that a woman's not getting pregnant? Maybe things that aren't typically thought of, things that are missed a lot. What do you see for those?
I mean, number one on my mind is endometriosis. It's just
Yeah,
so easily missed. It's kind of like, I don't, it's just, it takes so many forms. And everyone thinks it's just severe, severe pain during your period,
right.
or pain with intercourse. And that's it. They think those are the two symptoms, but it
Hmm.
takes so many forms in so many women. So it could be infertility, extreme fatigue, iron deficiency, anemia,
Right.
GI issues, either constipation or diarrhea, or IBS is a diagnosis, interstitial cystitis,
Mm.
radiating pain, or no pain sometimes, and mainly infertility and a lot of brown bleeding, for example, at the end of the period. Uh,
Hmm.
so it's migraines I see.
Oh yeah.
Just, yeah, I mean, it's a state of inflammation, and everyone's
Hmm.
immune system is so different, and everyone's endometriosis disease is so different. So no two women are going to ever present the same with endometriosis, which is part of the reason why it's so elusive. And then
Yeah.
add on to that, the diagnostic tool is surgery. And you really, obviously, it's not the first thing you want to jump to, especially if you're questioning the possibility. First, you're questioning, am I really suffering? Most women do that to themselves. And
Yeah.
then and then they say, well, then do I really have that disease? So then do I really need surgery? And so that's a lot of obstacles just with yourself. And I had endometriosis surgery myself. I went through the same thing,
Wow.
questioning it, even though I hit a whole bunch of symptoms. It took me treating many, many women with endometriosis to finally say, I have a very slight suspicion. I may not even have it.
You
Same thing.
stop gaslighting
I
yourself.
totally did. That's just normal. That's just part of it. That's part of
Yeah.
the disease, which is part of the barrier to care. Add on to that, very poor information given in medical schools as far as education of this
Right.
disease. It needs a multidisciplinary approach, but I have to beg oftentimes subspecialists to take me seriously with this disease or other issues like chronic endometritis, which we'll get into. But there's such a lack of knowledge in women's
Mhm.
health across all specialties.
Definitely. Do you find that in terms of infertility, do you see PCOS being something that's more so of a roadblock, or do you see endometriosis or endometritis? There's a kind of a mix.
Yeah, I would say, I mean, statistically worldwide, they say PCOS, I think, is more common, but
Yeah, but I don't know.
I think it's endometriosis.
Yeah,
And women with PCOS can have endometriosis too, right?
true.
So again, I see PCOS as much more treatable medically than endometriosis. So,
So,
lifestyle, progesterone,
yep.
supplements respond. Again, it depends on the case. We have very severe women with very severe PCOS that I do
Mhm.
surgery on, but I've had women heal themselves.
Yeah. I had PCOS and here I am pregnant and I don't think I have it anymore. So it's pretty cool. But with
Kind of a superpower
endometriosis,
like that.
I know, what's
Yeah,
up?
that makes sense. Yeah.
With the endometriosis, obviously when you're doing the surgery, you're removing tissue where it shouldn't be, but how else do you typically manage that long term?
Endometriosis, all the things.
Hmm.
Yeah, so great question. So first you have to find it, right? And then
Yep.
surgery is the foundation to know you have it, to acknowledge where are all these issues. Like it all comes together. Everyone's like, it all clicks. All the pain,
Yep.
all the fatigue, all the weird rashes, all these things all click. So just knowing what you're dealing with, then you can
Yep.
kind of target your approach. So the foundation is surgery, diagnosing and treating, removing the disease.
Mm-hmm.
Then at the 12-week mark, I meet with them for a comprehensive plan, kind of see the big healing milestone is 12 weeks, where the majority of
Mm-hmm.
healing is better. And I want to see how much pain is still going on or other symptoms. And we're going to build upon that after that. So it could include physical therapy, hormones. So progesterone's anti-inflammatory and it helps with bleeding and mood and cycles and just so many things.
Yeah.
So bioidentical hormone therapy that works cooperatively with the body, not suppressing it. So I use
Mm-hmm.
it kind of like people use birth control, but with bioidentical hormones. So it's
Mm-hmm.
fertility friendly, it's less side effects, healthier.
Mm-hmm.
Um, so then we also may do supplements or other lifestyle things. I have them trial and error different, food things, maybe eliminate a few things. It just depends on the individual case.
Totally. Yep. It's very individualized. Do you find that they have to keep having surgery, or how does that go with procedures in the future?
Yeah, I haven't calculated my own repeat surgery rate, but it's pretty low. So it's somewhere between 0 to 25% based on the data with proper excision surgery. It's lower when you get them in younger, thorough
Mm-hmm.
excision surgery and earlier stage. So the more advanced, especially if you have big balls of endometriosis in the ovaries called endometriomas, the more likely they're going to need repeat surgery. Also,
Mm-hmm.
if you don't do adhesion prevention measures, they're more likely to have pain or ongoing infertility. So
Mm-hmm.
it's really important to do it well the first time.
Yeah, definitely. Can you talk about, it was just, I think is such a cool procedure, the ovarian wedge resection surgery. And you guys have to go on to Dr. Whitaker's Instagram because there's a lot of really cool visuals with this procedure. I know when I was doing some research before this recording, Chat GPT, what does he know or she know?
Oh,
But
imagine me about
just
this.
yeah, saying that like the wedge, sometimes that doesn't need to be used anymore for X, Y, or Z. But I mean, it seems like it's still a really great procedure. And then when you would post about it on Instagram, I would go through the comments and it was like countless comments of women saying, I had this done and boom, I got pregnant. I had this done, boom, I'm pregnant. I mean, just so many, or so many saying how much it helped their symptoms that they were just suffering from. So I think that also is very, important information to look at.
So PCOS is a very complicated condition similar to endometriosis, very poorly understood. There's likely different subtypes that we don't understand, and there's different severities. So yeah, there's a
Yeah.
subset of women that can heal themselves through diet, lifestyle. But there's a subset of women, they are optimal everything. I mean, they have done everything under the sun and then
Yep.
some. They're 100 times
Mhm.
healthier than me or majority of
Mhm.
people.
Or me.
Yeah, and
Yeah.
then they're still struggling. Their testosterone's still through the roof. Their LH-FSH ratio on cycle day 3 is backwards. So that's saying that the brain ovary connection is reversed. It's just kind of,
Mhm.
it needs a reset. So the computer is frozen and it has this feedback loop that's just stuck.
Yeah.
So there's different ways to reset that. And sometimes progesterone can help. With that, it takes a while with cyclical uh, dosing of progesterone. That's a thing with
Mhm.
naturopaths more often in the literature. Uh,
Mhm.
but some women try that and that doesn't work, or they try ovulation meds and they just aren't responding. So we're talking women
Yep.
with very severe types, and their testosterone is just lighting up, on the result lab results, all red.
Mhm. Yep.
So these are the women we're talking about. They've tried all these things, it's not working. So, what we often see, these women's ovaries are quite enlarged, like huge, sometimes the size of the uterus.
Mhm.
And so I talk to them, what have you tried? Let's look at your labs. And especially if the testosterone's high, LH-FSH reversal, and they've failed medical therapies, I offer this to them. And it's the original treatment for PCOS by those who found and discovered PCOS, Stein Leventhal.
Fascinating. Been around for a long time.
Yes, it's the
Mhm.
original treatment. And I don't think anything will be able to replace it.
I don't think so either.
Yeah, some things are just classic. Like endometriosis, you're going to have to cut it out eventually.
Yep.
That's
Right.
the only way that disease is ever, I think, likely going to be treated.
Yeah, once that problem's there, that's what you got to do.
Right. So same with PCOS in these very severe cases. So what we do is we cut a slice out, kind of looks like an ovarian, like sorry,
Like a pizza or like a pie.
yeah. Or I compare it to, a piece of orange. When you're
Yeah,
taking an
right.
orange apart, it looks like that. And so we cut a wedge out and try to make the ovary a more normal size. That's our goal with the size of the wedge that I'm taking out. And so their AMH is really high, right? So their ovarian reserve, I mean, there's nuance in that. But let's just say their AMH is through the roof. So there's all these follicles that aren't being used because they're not releasing their eggs. Because that's one thing that we worry about. Okay, we're cutting out part of the ovary, but they're not being used, right? It's just inflamed and enlarged. So we cut this ovary down to a normal size, and 80% will have, well, 90% will start cycling on their own after that without any further medical intervention. So it's nice for women that are like, I don't want to use progesterone forever. I'm not, I just know myself, I'm not going to be able to do that with my life.
Yeah.
90% of them will cycle pretty regularly after that. And these are women that previously were often going 6 months without.
If that was like a result that a drug could do, that would never not be sold out. I mean, those are amazing stats.
Yeah, I mean, we lost this art when Clomid came along. Everyone
Right.
thought Clomid would be the next breakthrough. We wouldn't need surgery anymore. And surgery used to be a lot worse. We didn't have minimally invasive techniques in the 60s when Clomid was invented. And so, yeah,
Hmm.
I mean, surgery was much more risky as far as scar tissue and complications, staying in the hospital, big wounds. And things have changed since the 60s in surgery. Minimally invasive surgery was invented in the 70s, but we didn't look back. The art of
Hmm.
the wedge resection was lost in that time.
Right. So it was done a lot more readily for a while, and then it's not done as much now because of
Correct.
those drugs. But
Yeah.
yeah, I mean, I think it's a much better option in, probably most cases.
But medical
Hmm.
schools and physicians only think about 1930s, how there was
Right.
scar tissue, and they don't realize, oh, let's add minimally invasive techniques now and less
Yeah.
adhesiogenic sutures and these
Hmm.
techniques. And the risks are very low for young,
Yeah.
healthy women, and surgical use the proper surgical principles to minimize scar tissue
Hmm. So how
formation.
long does this procedure take to do, and what's the recovery look like? And yeah.
Well, I usually combine it with a lot of other things.
Hmm.
Tubal assessments, uterine assessment, cultures. The actual wedge resection, I can probably do each side 20 to 25 minutes per side or so.
Okay. Hmm.
But you add setting up the robot, doing all the other stuff. So, and finding endometriosis. So, average, all that does take about 3.5 hours. But you go home the
Hmm.
same day, and hopefully that is a game changer or a life
Yeah.
changer.
Yeah. I mean,
Some
you
women,
can have regular cycles within a couple cycles, right? Within a couple months.
yeah, definitely by 12 weeks. I know.
Hmm.
I'll recheck the testosterone, and it typically drops by 50 to 70% by then.
Yeah, I really want anyone listening who has dealt with, fertility challenges and you've tried everything. I mean, there's always going to be a small percentage of people that's the case. So look into this. Definitely check out Dr. Whitaker's Instagram and look more on this procedure. But it's probably something that your doctor hasn't mentioned to you that maybe you don't know is even a thing. That's why I love doing this podcast, just to give people knowledge that you wouldn't get. Maybe you're in the middle of nowhere, and or even in big cities, like you may not necessarily have this as an option where you are. So people probably come to see you from all over, right?
Yeah.
Yeah, I mean, for good reason, definitely. Any more, tell me just anything else about the fertility surgeries you think are good to touch on, like tubal surgeries? What are other kind of surgeries you guys are doing?
Yeah, I mean, most endometriosis surgeons don't know how to get disease off the tubes without just taking the tube out. So
Right.
you have to be really careful with screening your surgeon. I made a course about that if you are wanting to keep your fertility preserved or
Okay.
enhanced from surgery.
We'll put that in the show notes. Anything that's like specific resources like that, we'll put in the show notes for sure. That'll be a big value for specific people for sure. Okay.
Screening your surgeon, would you ever remove my tubes in what case or any organs? Some surgeons are quick to remove organs. It's a lot quicker, easier, and some physicians aren't trained on reconstructing an ovary or a tube. That's an
Hmm.
art, and it takes time to learn and to do it, and it's not really reimbursed either. So there's no incentive.
Right.
And unfortunately, with training of OB-GYN, you have to think about it's really split. You're either a fertility specialist doing IVF or you're a surgeon treating pain. There's not really someone that combines the two of someone who
Hmm.
wants to focus on fertility preservation and pain management.
Hmm. Yeah, it's usually
So,
done together.
yeah,
Hmm. So let's dive into endometritis. So not endometriosis. This is different. This is a chronic condition. How are you diagnosing this? And yeah, just more about this.
sure. So symptoms can be none. So chronic endometritis is inflammation inside the uterus. One of the most common causes is due to an infection, and it could just be there for a long time. You don't even know until you try to conceive. And again, this can be toxic to anything that's in the uterus that you want to be there, such as sperm
Hmm.
or implantation. Some of the symptoms we might see, so infertility, tail and brown bleeding, at the end of the period, especially 3 days or more, just kind of trailing off dark brown or black blood, like when you wipe,
Hmm.
not on the pad.
Hmm.
So we offer swabs basically to almost anyone with some of those symptoms. And so we can do
Hmm.
swabs in the clinic, or I like to also repeat them in the operating room because it's technically a sterile environment, as sterile as you can be. And
Hmm.
I have much more access to a variety of cultures. So viral, fungal, bacterial, aerobic, anaerobic, ureaplasma, mycoplasma. We check for CMV,
Wow,
a
that's
whole bunch of things. We
amazing.
find some crazy bugs that,
Really? What have been some curveballs? What do you what
oh
have you
gosh, I
come?
mean, Canada cruzi. I don't know, things I've never heard of. That was the one
Wow.
recently I'm working on, and E. coli and Pseudomonas and MRSA, and I mean things you
Wow.
really. I mean ureaplasma, mycoplasma all the time. CMV.
Wow.
There's no cases out there, so I have to make up protocols essentially based on obviously my medical knowledge and reading literature, which is often based on cow studies
Right.
because apparently animals are worth more than humans because of them being needed for farms. Um, and I just met with an infectious disease doc that I do refer patients to when it gets to the point where they failed oral medication, they might need an IV,
Hmm.
like a PICC line or something. I send them to the infectious disease. Maybe they can think of something a little less invasive. Um, I talked to one the other day and he's like, I found no literature only on animals. And I was like, yes, thank you. Welcome to my world. Yes.
Right.
Are
Seriously.
an uncharted territory. We got to figure this out. I mean, it's kind of fun in a way. It's interesting, but it's hard because it's like, well, I don't have data.
Right.
Hopefully the culture is sensitive. We try to run sensitivities on the rare things, but there's no protocol.
So
So
do you do like a local treatment for that, or is that more systemic once you kind of figure out what's going on?
systemic, yeah. It's really hard. It's a great question because it's really hard to penetrate the uterus because the uterus is
Right.
meant to protect the the baby from the maternal environment, from the maternal immune system. So
Hmm.
only certain antibiotics and treatments penetrate the uterus, and you need a prolonged
Right.
therapy, at least 14 days, if
Hmm.
not more, depending if it's a fungus or bacteria.
I wonder if
Uh,
anyone's tried to do like a local treatment where you can go through the cervix and,
yes,
get it taken.
there's one Toth, Dr. Toth. He has a book. It's kind of weird, some of the stuff in there, but
Still work
we
in
did
progress on that.
he's older, I think at the end of his career, but some of this stuff in there I don't agree with. But he is one of the leading physicians that's been working on this, and he thinks
Mhm.
all roads lead to chronic endometritis. I don't totally agree with that.
Yeah.
That's one of the things I disagree with. I do think it's common,
Yes. And
and
commonly missed for
it's
sure.
commonly missed because it's so subtle and so easy to treat. Majority of the time, there are exceptions to that. But yeah,
Hmm.
he does a lot of uterine washings would be his thing. Or we had a case that we referred to him years ago, not me, one of my partners. Um, and would even inject prostates with
Wow.
antibiotics. So, I mean, intense for, I mean, a man's
Yeah.
doing that. That's
Yeah. He's a renegade. So for people who are listening who are like, I think I might have endometritis, I mean, so would be chronic BV also be something that they would
Yeah.
see
Hmm.
potentially? Um, so yeah, what could they ask their doctor, to do? Or is this something they can check on their own? Like, how can they navigate this if they're suspecting this?
Yeah, I think patients could likely, well, could definitely request that. So
Yeah.
cervical or endometrial swabs, you have to make sure you're not pregnant because
Mm-hmm.
you do the endometrial swab. That's a swab up inside the uterus. I think that's the most accurate, but next best would be endocervical.
Uh-huh.
And hopefully they have either an aerobic, anaerobic culture,
Mm-hmm.
ureaplasma, mycoplasma, fungal. And
Okay.
also, yeah, any vaginitis panel would be beneficial too. The more
Yeah.
swabs, basically all the swabs they can get.
Mm-hmm. Do you guys see this in pregnancy a lot?
We do like women that are pregnant with
Yeah.
with these.
Yeah.
So we have had that. We try not to screen in pregnancy. Hopefully we do it before.
Right.
I've had women who had, I could think of a case, stage 4, I believe, endometriosis removed. We found ureaplasma. We treated it, but it was resistant, which is common.
Mm. Mm.
She ended up still having it in pregnancy. We threw all this other stuff at her, never cleared it. We monitored. She was able to have a healthy term baby. Everything was fine.
Wow.
But of course, it made us nervous. And
Yeah.
I mean, sometimes it's kept in check by the body, and thank goodness it does. We'd rather
Mm.
not worry and clear it before. We like to do a test of cure once we treat them to make sure it's gone. So we'll swab
Mm-hmm.
again a few weeks after treatment's complete to make sure it's gone, to kind of give them the clear. I had one, she had 2 or 3 infections in her uterus, very mild endometriosis. I really think that was her thing. So I remember seeing her in clinic. I want to say it was like a Thursday. I said, we did test or we got the cultures back. Everything was good. I said, you're good to go. You can try to conceive. The next day, she literally conceived. I couldn't
Wow.
believe it.
It's amazing.
I, one of the coolest cases. I mean, I think she had 3 bugs in her uterus. And wow. And I mean, sometimes, unfortunately, especially with multiple bugs, that often leads to a lot of complications in the second trimester. We see
Mm.
losses of
Interesting.
pregnancy. And so I'll swab patients since we do obstetrics as well. I'll swab them. I'll have the midwives take my culture panel from the OR and offer to swab women, and we'll find bugs.
Mm-hmm. Oh yeah. Fungal too, right? For
Oh
women who have
yeah,
a lot of
yeah,
exposure. Yeah, I've seen that when I clear mold issues for patients. I've seen a huge improvement with fertility. So it makes sense. Yeah. So for let's say you identify the root cause of someone's endometritis, you mainly using like oral antimicrobials and then doing some work to just kind of restore flora and all that after that.
yeah, yeah. So we'll
Mm-hmm.
treat both. We'll offer both the woman and the man to treat.
Mm-hmm.
And I've had one case where it came from the man. He had something he was born with, and he
Oh
kept having
yeah.
reflux. And we kept treating her. And then I guess, I don't know how. Sometimes we wouldn't treat him, I guess. I don't remember, it was such a long
Yeah.
time. And we finally figured out it's him.
Wow. Kept passing things back and
Yeah.
forth. Yeah, that happens. Wow, that's so fascinating. Well, I could talk about endometritis and all these things all day. Is there any other, pieces of this that we should touch on for people? I know you have a lot of amazing resources, and we'll put those in the show notes for you guys who want to do some more digging. But yeah, any other
I mean, I think
fun?
they're on the right track listening to you, educating themselves, cycle charting, really formally getting instruction on your cycle, knowing exactly what days you're fertile, your peak day of fertility. You can identify what's normal in your body and technically red flags as well. You can see changes over your whole life, which is
Mm-hmm.
really incredible. Cervical mucus is key as well, just knowing when and if it's good quality. Um,
Yeah.
and just really advocating for yourself. No, you're going to be your best advocate. If you cycle chart, especially if you're formally taught and you listen to in-depth podcasts,
Mm-hmm.
they know more than your doctor.
Oh, like a lot more. A lot more. We're
Same
being
time.
nice. We're being nice. Yeah, no, you guys are the fact that you are listening and watching this, and especially this far into it, you are a very specific sector of people,
Yeah.
and probably you know a lot. Well, Dr. Whitaker, I really appreciate you being so generous with your time and just taking the time to share your own story and a little bit about what you do. I know you're going to be reaching thousands of women who need this information, and you provide so much hope for them when they just feel like there's no other options. So I really appreciate what you do. I'll make sure to put your information in the notes and people can follow you. But yeah, just really appreciate you being here and what you do.
Such a pleasure. Thank you so much for having
Of
me.
course. It's been a joy. And I might have to bring you back on because you can talk about a lot of things.
I know
So,
we could talk for hours.
yeah, for sure.
Problem.
All right. Well, we'll catch up soon.